Today, we are very excited to have Dr. Jessie Walker joining us. Dr. Walker is originally from Indianapolis and received a Bachelor of Arts from Stanford University, where she majored in human biology and competed also on the varsity swim team. She attended the University of Wisconsin for medical school and then subsequently matched here at UW for OBGYN residency. Her research interests are centered around postpartum sexual health, and she also teaches a biannual workshop on postpartum sexual health through Meritor's Baby Hour, as if she weren't busy enough already. After graduation, she looks forward to remaining in Madison with her husband and 2 daughters, where she will be joining Physicians for Women, so we'll be lucky to have her around. Please join me in welcoming Dr. Walker this morning.
Good morning, everybody. Today, I'm very excited to talk about a topic that I'm very passionate about. In January of 2019, when I was a 4th-year medical student, my daughter, Charlotte, was born. I attended an open support group for postpartum mothers who delivered at Meritor called Meritor Mother Baby Hour. And it was an amazing resource for me as I was navigating the new and wonderful and terrifying transition of becoming a new mom. We shared stories, advice, and solidarity weekly for the first 3 months of our babies' lives. A phrase that I heard with great frequency was, "Nobody warned me about this part." The night sweats, hair loss, mood swings, breastfeeding concerns. There was so much that we weren't prepared for. When I entered residency, Charlotte was 4 months old, and as an intern, I rounded on hundreds of postpartum patients throughout the year. And I found myself struggling to answer a lot of their questions. I didn't have any data or concrete knowledge on so many of these seemingly simple issues, and I found myself either answering questions based on my own personal experience or punting with answers like, "Your nurse is a great resource for questions like this." I began to wonder why we don't have more education on the common changes experienced by many patients in the postpartum time. My hope is that today will provide additional data-based information to help you answer the next postpartum question that comes your way. I have no disclosures. My learning objectives for this talk are first to define the 4th trimester and outline its importance in obstetric care. Second, to review what the average patient experiences in the immediate postpartum period at Meritor Hospital. And finally, to discuss common complaints in the postpartum period, highlighting normal physiology and when treatment should be recommended. Before I start, I want to touch on inclusive language throughout this presentation. For many of our patients, words like mom or mother are acceptable, but I recognize that this is not the case for every birthing person. I will strive to use inclusive language throughout this presentation, and I do recognize that my default terms may not always be the most accurate description for every patient. Our agenda today will go something like this. So let's start by discussing the 4th trimester. Within the last decade, ACOG has started to emphasize the importance of the 4th trimester, or the 12 weeks following birth. This period of time is just as important as the first 3 trimesters and has significant implications for physical, mental, and emotional well-being. This period of time looks different for everyone and certainly different on social media compared to real life. Some people paint a picturesque portrait of the newborn period, while others are more upfront with the realities of postpartum struggles. While the wave of honest experiences on social media has paved the way towards normalization of many of the real-life challenges for new parents, many postpartum patients still suffer alone, worried that what they're experiencing is abnormal, embarrassing, or without available treatment. This is why we should aim to discuss the components of postpartum care with all of our patients, regardless of age, parity, or delivery route. So what are these components? The ACOG Postpartum Toolkit is actually a really wonderful resource, and the practice bulletin is well written and helpful. If you haven't taken a look at it recently, I highly recommend you do so. It breaks down the 4th trimester into a number of different components as depicted here. Because each of these facets is important, the ultimate goal is to cover all of these topics with our patients, with additional emphasis on certain areas tailored to each patient's unique needs. We'll touch a bit more on the formal postpartum period at the end of this talk. But let's move on from here and talk about what happens in the immediate postpartum period at our institution. So to set the stage, imagine you delivered the baby, the placenta's out, and you're rushing off to the next patient who needs you on labor and delivery. Before you go, the patient says, "What happens now?" Naturally, patients want to know what the next several days of their hospitalization will bring. Of course, every patient is different with unique circumstances, but this is a general outline of what patients can expect after delivering at Meritor. The immediate postpartum period is referred to as the golden hour. This is a crucial period of time for a delivering person and their baby. Ideally, skin-to-skin contact will be initiated immediately after birth, and the first attempt at breastfeeding will occur within this hour if that's how the patient wishes to feed their baby. If the patient desires, we should avoid weighing and measuring the infant during this time to facilitate skin-to-skin contact. There's very strong data that demonstrates objective benefits to a newborn who is able to spend the golden hour with mom. These benefits include glycemic and vital sign regulation, as well as improved rates of breastfeeding. This is something that we should take into consideration when dealing with complex laceration repairs, postpartum hemorrhages, retained placentas, and other acute maternal situations that may separate mom and baby. As we coordinate efforts to take good care of our patients, we should facilitate skin-to-skin contact if at all possible. After this golden hour period, patients remain on L&D in recovery for several hours depending on their mode of delivery. Fundal checks are performed every 15 minutes by nursing staff for the first 2 hours and then every 30 minutes for the next hour. Thereafter, these are performed every shift. They will be transferred upstairs if their bleeding and vital signs are stable and their pain is well controlled. After the transfer to postpartum, we are all likely familiar with the milestones for the delivering person, like ambulation, voiding, pain control, return of bowel function. Baby also has some important milestones that happen at discrete points of time. At 12 hours of life, babies can have their first bath if desired, and they're given the hepatitis B vaccine. This is also the soonest that they can perform the hearing test, so this is often done at 24 hours. Also at 24 hours, the Wisconsin newborn screen is performed, as well as a bilirubin draw. And other tasks prior to discharge include filling out a birth certificate, blood sugar testing if applicable, the car seat test, and circumcision if desired. If mom and baby are doing well, they can be discharged after all of these tasks are complete. Now that we've set the stage, let's move on to the meat of our discussion, which is postpartum head to toe. We will quite literally move down the body, reviewing common complaints, normal and abnormal physiology, and interventions for some of the most frequent problems encountered in the postpartum period. Let's start with the head. During pregnancy, the normal progress of hairs from the anagen or growing stage to the telogen or resting stage is slowed. This leads to a relative increase in denser hair, and it's why patients often report thicker, fuller hair during pregnancy. Postpartum, in contrast, is typically associated with hair loss, and this is formally known as telogen gravidarum. Due to the drop in estrogen in the postpartum period, there's a relative increase in telogen hairs, which results in more hair loss and less hair growth to compensate. This process usually peaks at 2 to 5 months after birth and resolves within 15 months. It's common for patients to also notice changes in hair loss when ovulation resumes or during breastfeeding weaning when hormone fluctuations are occurring. While telogen gravidarum is common, persistent or severe changes in hair loss should prompt workup for pathologies such as postpartum thyroiditis, anemia, or depression leading to poor nutrient intake. Before we move on from the head, I thought it remiss not to at least mention postpartum mood disorders. Because we do get a lot of education on this topic, I'm not going to spend a great time going into detail today, but I want to emphasize that this is something that we should be screening everyone for at every clinical encounter. Another very common symptom experienced in the postpartum period is night sweats or hot flashes. This symptom is defined as a subjective feeling of heat without an actual increase in core body temperature. And importantly, this is different from a postpartum fever, which will have an increase in core body temperature and could be the sign of an infection like mastitis or endometritis, just to name a few. This phenomenon can be attributed to the drop in estrogen at the time of birth, often to menopausal levels, thus vasomotor symptoms like seen in menopause. Additionally, since prolactin further inhibits estrogen, breastfeeding patients are more prone to experience this symptom. Hot flashes or sweats most commonly occur at night, but it can occur at any time of day and usually subside by 6 weeks postpartum. Similar to telogen gravidarum, severe or persistent temperature symptoms should prompt workup for pathologic causes, namely thyroiditis. As we work our way down the body, let's take a quick detour from the trunk to the upper extremity. De Quervain's tendinopathy is a common complaint that's often overlooked as patients are unlikely to report hand issues to their OBGYN. It presents as pain at the radial side of the wrist, often worse with thumb and wrist movement. There may also be associated swelling and tenderness. It's generally an overuse injury and is commonly seen in postpartum patients due to the movement necessary to pick up and hold an infant. When taking a history, this is an atraumatic wrist pain, so no history of falls or other injury. Exam will demonstrate tenderness of the radial styloid, as noted here, and a quick and easy test that is generally diagnostic of de Quervain's is known as the Finkelstein test. You ask the patient to grip their thumb, and then you kind of extend their arm and you extend the radial side of the wrist, and if they have pain, that's relatively diagnostic of this. First-line treatment includes occupational therapy referral, NSAIDs, and rest. Okay, let's go back to the trunk where we're all more comfortable. Lactation is certainly a pivotal topic for many postpartum patients, so we're going to spend some time exploring it today. Before I start this section, I want to recognize the amazing wealth of knowledge of our lactation colleagues. Today's discussion is meant to provide a very general overview of early lactation and common patient concerns. But when in doubt, we should always refer our patients to the lactation team, who's available prenatally, inpatient in the postpartum period, and also as an outpatient after discharge. As a brief aside, something I learned while preparing this talk is that lactation at UW Hospital specifically is available to be consulted for any lactating person, regardless of the reason for admission. So if a patient breaks her ankle and is admitted 6 months postpartum, you can consult lactation for help with pumping needs while she's in the hospital. Additionally, lactation consultants are available for any UW employee, free of charge, for help with lactation needs while at work. Taking a step back to antenatal counseling, I've had several patients ask me about colostrum expression and pumping while pregnant. This is gaining popularity with patients, especially as the internet forums like TikTok lead to dissemination of information. The breast starts producing colostrum between 16 and 22 weeks gestation, and many patients will notice leakage from the nipples during pregnancy. This is normal and not cause for concern. However, the idea of purposefully expressing colostrum prior to delivery is somewhat controversial and relatively poorly studied. The largest study to date was called the Diabetes and Antenatal Milk Expression Study, or the DAME study. This was a multi-center unblinded RCT of women with pre-existing or gestational diabetes. Patients were randomized to antenatal expression starting at 36 weeks versus no expression. The study failed to demonstrate a significant decrease in NICU admissions for glycemic control between groups. And there were also no significant adverse events in either group. So overall, not really compelling results in either direction. That said, it's a practice worth considering in some patients. For example, diabetic patients whose infants may struggle with hypoglycemia. As per the DAME study, this is unlikely to actually reduce NICU admissions, but it may minimize the need for donor milk, which some patients may be uncomfortable with. It can also be considered if there are suspected fetal facial anomalies, which may make putting the baby to the breast more challenging. In addition, if there's a planned NICU admission or a planned mother-baby separation, having some colostrum on hand may reduce the need for donor milk or formula. For the general population, however, it's appropriate to counsel patients if there's no data to support this practice for the purpose of increasing supply alone. And that's the reason that many patients are actually inquiring about it. It's also important to counsel patients that nipple stimulation can cause preterm contraction in some patients, so this generally should not be done prior to 37 weeks in most people. The composition of human milk goes through a complex evolution over time to meet a baby's needs. Colostrum, as we just discussed, starts being made during pregnancy. Expression can typically start immediately after birth, and colostrum continues for 2 to 5 days. It's thick and yellow and provides high density calories that are rich in protein and low in fat and sugar, and also has a high proportion of antibodies from mom. Next comes transitional milk, which the breast starts producing 30 to 40 hours after placental delivery. However, most patients actually notice breast fullness around 2 to 3 days after birth, as it takes more time for that transitional milk to accumulate. This is commonly referred to as milk coming in, which patients will ask about. This is the time when first engorgement also occurs. Generally, transitional milk production starts earlier with increasing parity. So the average time for a prime-ep is between 3 to 5 days after delivery, and a multip is 2 to 3 days. Finally, mature milk comes on the scene around 2 weeks after delivery. Its concentration is ever adapting to fit baby's needs as he or she grows. Thinking back to that transitional milk, the process of creating this milk is referred to as lactogenesis. It's hormonally driven and begins with the progesterone drop that occurs after placental delivery. We know that early expression right after birth has several important benefits in a lactating person and their baby, including higher milk production at days 3 to 4, less infant weight loss, and lower bilirubin levels. Because of this, we generally recommend starting the breastfeeding process as early as possible so babies and parents can start learning how to breastfeed. Despite this general recommendation, immediate expression of milk is not crucial to maintain breastfeeding at the very beginning. Current evidence suggests that what really impacts milk supply is a failure to express the breast prior to the peak onset of lactogenesis, which again is around 30 to 40 hours after placenta delivers. This is because milk production is driven by supply and demand, and if the breast fills without being emptied, the body will begin to shut down production. I think of this information as data to reassure patients who for various reasons may not have been able to initiate feeds or pumping as early as they planned. As long as the breast starts being emptied really within the first 24 hours, breastfeeding can still be successful. There's some risk factors for delayed lactogenesis that we as providers should be aware of. Of course, we often don't have control over these factors, but it can be helpful to provide reassurance to patients that there may be a reason that their milk is not yet in. Regarding preterm birth specifically, it's not so much delayed as that there's less breast tissue developed, especially if a preterm delivery occurs prior to 30 weeks. Breast tissue should develop over the coming weeks if expression continues, and milk supply should increase thereafter. When counseling on the frequency of feeding or pumping, the short answer is a lot. In order to effectively establish milk supply, parents should empty the breast every 2 to 3 hours in the first several weeks of a baby's life. It's best to feed baby on demand, even at night. Some babies will have longer stretches of sleep overnight, and though tempting, nursing persons should not allow stretches of longer than 4 to 5 hours and should actually wake baby up to feed in the early weeks. Something that I see all the time on the postpartum floor is an exhausted nursing parent on postpartum day 2 or 3. This is often due to a phenomenon called cluster feeding, which occurs during the 2nd and 3rd day of life. Babies will nurse for a few minutes and then pull off the breast and fuss, and the cycle can repeat for hours. As you can imagine, this is a common source of exhaustion and frustration and can really impact a new parent's confidence. It's important to provide reassurance during this time that this behavior is both normal and temporary. Something that really frustrates me to hear is when a nursing parent is told, if it hurts, you're not doing it right. While this is probably accurate in the long term, the truth is that early breastfeeding is fraught with pain and discomfort as both mom and baby are adjusting to this new practice. I think in some ways telling parents this can impact confidence as they assume that they're doing something wrong if they're uncomfortable. Instead, we should shift the rhetoric to normalization that breastfeeding is natural, but not easy. We can provide reassurance of normal struggles and refer to our lactation specialist when pathology is suspected. So let's discuss some of the most common causes of pain. Cracked nipple is a common culprit. It results from nipple trauma, creating a fissure in the nipple tissue. This can cause exquisite pain, often reported as sharp or burning, and can actually radiate into the breast. Ensuring a good latch is important, as shallow or improper latch can cause or propagate nipple cracks, though not every cracked nipple is secondary to a problem with latch. Some helpful treatments include expressing a small amount of milk at the end of feeding, rubbing it on the nipple and allowing it to air dry. Other helpful ointments include lanolin, olive oil, or coconut oil. Basically anything to keep the skin moisturized that can help improve resilience, and you should use something that baby could consume. Plugged ducts occur when there is obstruction of milk in a portion of the breast, either at the nipple or further back in the ductal system. It presents as a lump in the breast that causes pain but no fever. There may also be a white spot on the nipple as the plug makes its way to the end of the duct. Importantly, plugged ducts can lead to mastitis and should therefore be treated promptly. Treatment consists of regular expression every 2 to 3 hours, and patients can also massage the breast, especially in the spot of blockage before and during expression. Many people also find warm packs before nursing to be helpful. Nursing bras should be well-fitting and not too tight, as tight bras can cause or propagate clogged ducts. Because breast size often fluctuates during the establishment of breastfeeding, formerly well-fitting bras may become too tight over time, and it can be helpful to remind patients to periodically assess the bra size if needed. Engorgement can be easily confused for mastitis. It presents as swelling, tightness, and increased size of the breast, sometimes associated with warmth. The nipple itself is often firm, tender, and swollen. This pathology is most commonly seen in the first 3 to 5 days after birth when lactogenesis is ramping up. And so when determining your differential diagnosis for a warm and swollen breast, remember that mastitis almost never occurs this early. Treatment for engorgement includes frequent expression as often as every 2 hours if engorgement is severe. Also, patients should be instructed to rotate which breast to start nursing on, as babies are more likely to empty the first rather than the second breast. Finally, Tylenol, NSAIDs, and cold compresses can help with pain and inflammation. Patients may also report intense pain during infant latching if their breasts are engorged. And this is because due to a tense nipple, babies have a hard time achieving a deep latch. Patients can use a backwards pressure on the nipple areolar complex to actually push fluid out of the nipple and make it smaller and softer, allowing baby to latch. Engorgement should subside within 12 to 48 hours if treated appropriately, but it can persist for 10 or more days if not treated. We do get a lot of education on mastitis, so this is another topic that I'm not going to go into great detail today, but I wanted to contrast that with engorgement to be clear on the differences. While both engorgement and mastitis have warmth, redness, and tenderness, mastitis typically has a sharper demarcation of the erythema, as well as systemic side effects like fever, nausea, chills, and myalgias. Also, as we already talked about, mastitis rarely occurs within the first several days after delivery. Pumping and dumping in the setting of medication administration is a common source of anxiety for many parents, and unfortunately, people are often recommended to do so more often than is actually necessary. Especially in the first few days of baby's life, first 2 days of life, babies take in exceedingly small volumes of milk at a time. Thus, medications that are borderline in safety are often safest during the early newborn period because of the amount of medication that they're actually ingesting. Unfortunately, there's not a lot of black and white in this topic as there's very little data on medication safety profiles in pregnancy and in lactation. The next several slides will review some of the common classes of medication and their safety profiles. To start, as a pretty consistent rule, these medications listed here are generally not safe. Statins, amphetamines, ergotamines, and chemo agents. There is no evidence to recommend discarding milk after general anesthesia as it reaches low levels in the breast milk. Notably, medications like ketamine and other opiates can contribute to infant sedation and should therefore be minimized if possible. As we just discussed, given the small volumes of milk taken in by neonates in early life, these substances carry less potential risk in young babies rather than older babies who consume more milk in a serving. So that's something that you can use to reassure patients who have a C-section under general, for example. Regarding analgesics, Tylenol is the preferred agent as this can safely be given to infants as well as in pregnancy, and it reaches low levels in the breast milk. NSAIDs with shorter half-life like Toradol or ibuprofen are safer than naproxen as there's less risk of accumulating in infant serum. Opiates are generally safe in low doses for short durations, though keep in mind that as exposure time increases, the risk of infant sedation also increases. We should therefore aim to limit opiate use to 2 to 3 days, and infants should be monitored for signs of increasing sedation. If a baby demonstrates symptoms such as increased sleepiness, difficulty breastfeeding, breathing difficulties, or limpness, a physician should be contacted immediately. Medications that heighten this risk of sedation include benzodiazepines and ketamine, and anything that contains codeine. Of course, limiting opiate use is not always possible, so thorough counseling and coordination with pediatrics should take place if prolonged opiate use is indicated. Meritor's institutional policies on our opiate choice in the immediate postpartum period warrant some additional discussion. As many of us are well aware, Dilaudid or hydromorphone is the default choice for our post-op patients. Interestingly, in a 2021 clinical consensus, ACOG recommended the use of low-dose, low-potency, short-acting oral opiates, including hydrocodone, oxycodone, tramadol, and morphine. They go on to say that stronger opiates, such as hydromorphone and fentanyl, are best reserved for individuals with inadequate pain control. This is an interesting contrast to the AAP's guidance from 2013, which recommends against oxycodone use due to the high percentage of excretion in breast milk. I spoke with Sarah Ganath, the primary OB pharmacist who helps make our order sets at Meritor, regarding our decision to use Dilaudid regularly, as this seems to be in accordance with the AAP, but against the ACOG clinical consensus. She provided an interesting historical perspective that I'm happy to discuss at the end, but essentially we're following the AAP's guidelines as listed here, and we've had very few adverse events at Meritor, especially after Duromorph was rolled out. As an aside, this publication is a really great resource for our many other medications in addition to opiates, and it's worth checking out if you have questions regarding medication safety and lactation. Imaging is sometimes indicated in lactating patients, and the safety of contrast is often a topic of conversation. CT contrast is considered safe, though data is limited. We believe that less than 1% of the maternal dose is actually excreted into breast milk, and less than 1% of that is actually absorbed by an infant's GI tract. If a patient feels especially strongly about pumping and dumping, we would recommend a 24-hour waiting period to ensure that all the contrast is out of her system. Regarding gadolinium, the previous recommendation was for 24 hours of pumping and dumping, but that's actually no longer the case. And similar thoughts as CT contrast, there's low excretion of breast milk and low infant absorption. Again, a 24-hour waiting period could be considered if a patient desires. I want to point out that the UW Department of Radiology has recommendations on radiographic considerations in pregnant and breastfeeding patients, and it's a really great resource for our department. It's easily searchable online. Shout out to Dr. Nettie Larson for alerting me of this. This table includes some of the most common antibiotics that we as OBGYNs prescribe. I know it's kind of busy, but the general takeaway is that most of the medications that we prescribe are safe, which I know we know, but it's a good thing to reassure patients on. Most of them are at risk of causing GI upset or thrush, and clindamycin is a slightly higher risk for this, but is otherwise safe. Interestingly, the data on Flagyl is really mixed, even though it's a medication that we use both in pregnancy as well as to actually treat infants. The takeaway from LactMed is that topical formulations should be fine. And if there's an alternative to oral IV Flagyl, it's worth considering using another agent. This marks the end of our breastfeeding journey. So continuing on with our postpartum head to toe, we'll move down the postpartum body to the abdomen. Diastasis rectus is defined as an abnormal separation of the rectus muscles. There's no well-defined standard, but up-to-date uses greater than 2 centimeters as a cutoff for diagnosis. Diastasis occurs when the linea alba is weakened, allowing for protrusion of abdominal contents between the rectus muscles. And importantly, there's no true fascial defect here. So this isn't a hernia process and there's no risk of incarceration or strangulation. The frequency of diastasis in pregnancy and postpartum is variable in studies, but one study using ultrasound during and after pregnancy demonstrated a prevalence of 100% at 35 weeks, which dropped to 39% at 6 months postpartum. Diastasis itself is not harmful, though many patients find it cosmetically unfavorable. Treatment consists of exercises that focus on strengthening the rectus muscles, and these exercises can actually be beneficial to start during pregnancy. Patients should be instructed to start with light weight-bearing exercises and generally increase intensity as tolerated. There's actually a lot of great YouTube videos online that we can refer patients to if they want to do some self-guided exercises. If a patient has significant diastasis or is having trouble resolving it with home exercises, this is a great time for a physical therapy referral. This slide was inspired by a question from an RCC patient I had in the fall. She was complaining of back pain after her epidural site at 1 week postpartum, and I wasn't quite sure what to tell her. It turns out it's very common for patients to have localized point tenderness for several days after epidural placement, and this alone should not be cause for concern. However, if accompanied by any of these warning signs, patients should be instructed to present urgently to the ED for evaluation as they may have a life-threatening infection. This risk is increased in immunocompromised patients and those with diabetes, so have a higher pretest probability with those patients. A lot of people are worried about an epidural causing chronic back pain. However, it's much more plausible that longstanding back pain after delivery is due to loss of core strength as well as labor positioning rather than the epidural itself. In fact, I could not find any convincing evidence to support that neuraxial analgesia causes long-term back pain. We'll focus on the pelvis for our last several topics today. A postpartum page about cramping is assuredly something we're all familiar with. This is colloquially referred to as after pains. This cramping is secondary to uterine contractions, which are encouraging involution to minimize bleeding and return the uterus to its pre-pregnancy size. Risk factors for increased pain include anything that may cause the uterus to be overdistended. Most commonly, this is seen in multiparous women, and additional risk factors include fetal macrosomia, polyhydramnios, and multiple gestation. Because oxytocin stimulates uterine contraction, breastfeeding patients typically report intense cramping during the letdown phase. And for some people, this pain may be so intense that it actually interferes with breastfeeding because they're afraid to nurse. A Cochrane review from 2011 evaluated 28 RCTs focusing on pain control for after pains in the postpartum period. Unfortunately, the conclusion was of generally poor evidence, but the authors overall felt that NSAIDs were better than opiates, which were better than placebo for the treatment of these pains. There is also very low certainty evidence to support acetaminophen herbal pain relief or TENS units. Anticipatory guidance for pericare is really important as this is a source of high anxiety for many patients after delivery. Generally, pain should improve each day, and by 1 week postpartum, most patients do have minimal pain, though this may take longer if there's an oasis or another complex laceration. If pain seems to be worsening rather than improving, this should prompt evaluation. Mainstays of pain control include ice, benzocaine, and witch hazel pads, in addition to ibuprofen and Tylenol. Patients should be cautioned against scented pads as they often cause irritation. The PERI bottle is very important to instruct patients on, especially if there are periurethral lacerations. In fact, I actually had an ED consult on a postpartum patient yesterday with pain, and we re-talked about the PERI bottle because she was having a lot of stinging with urination. When I'm explaining my repair after delivery, especially if a patient has a periurethral laceration, I start to talk to them about how to use the PERI bottle. I tell them to fill it with warm water and start spraying it on the perineum before they start urinating, the whole time they're urinating, and then for a little bit afterwards. And the point is to minimize the amount of acidic urine that's in contact with the laceration, as this can cause a lot of discomfort. Sitz baths can also be helpful if patients have painful urination or for general hygiene. If you're like me and have been recommending sitz baths for years without actually knowing a true definition, here's one. It's just a shallow, clear water bath without any water additives that bathes the perineum and buttocks. It's for short durations and up to 5 minutes and several times a day. Other important patient education includes suture care. We should reiterate that all stitches dissolve, and patients may notice suture fragments on toilet paper and their underwear in the coming weeks. This is normal and not a cause for concern. Finally, emphasis on constipation prevention after delivery, regardless of route, is very important. Lochia is experienced by every postpartum patient, regardless of delivery route. Normal lochia has a very characteristic color and smell, and patients will notice a change in the color from bright red to a watery yellow over the course of several weeks. The volume should steadily decrease. Any abnormal characteristics as listed here might indicate pathology and should prompt evaluation. Vaginal atrophy is a common issue that many patients start to notice several weeks after delivery. Similar to several other complaints we discussed today, the physiology is tied to a loss of estrogen, which puts the body into a menopause-like state. Because prolactin suppresses estrogen, this can be longer lasting or more profound in breastfeeding patients, although formula feeding does not necessarily exclude the possibility of vaginal atrophy. Many patients find that over-the-counter lubricants and moisturizers are sufficient, but if a patient is having persistent bothersome symptoms, topical vaginal estrogen can be quite helpful. When dispensed by pharmacy, this tube comes with an applicator, which helps get the medication into the vagina and not just on the labia. However, some people may have pain with insertion of this applicator, especially at the start of treatment if they had a perineal laceration. So you can caution them on this and tell them that they can use a finger for application at the start if that's helpful. While there is a theoretical risk of estrogen impacting milk supply, we know that the systemic absorption of topical estrogen is very low, so we can reassure patients that this should not significantly impact lactation. We know the pelvis goes through significant adaptations during pregnancy, and delivery can also lead to trauma and alterations in the pelvic floor. Ongoing pain is often due to a loss of muscular strength, as well as a rapid change in gait due to the return of a normal center of gravity once there's no longer a baby. Light exercise routines and pelvic floor PT are the best ways to regain this strength and improve pain. Again, YouTube has some great postpartum exercise routines that can help patients start to restore strength and function of the pelvis. Incontinence is a common feared complication after birth. Urinary incontinence is relatively common and generally permissible in the early postpartum period. As the pelvic floor strength is regained, this should improve. If symptoms are persistent around the time of the postpartum appointment, referral to urogyne is appropriate. In contrast, fecal or flatal incontinence really should never be classified as normal. And if a patient is having issues past several days postpartum, they should be referred to urogyne. Generally speaking, everyone who has a baby would probably benefit from seeing pelvic floor physical therapy. They're an excellent resource and can help with pain, incontinence, sexual dysfunction, and many other issues. Finally, I just want to touch on the postpartum visit. This by itself could occupy an entire talk, but I wanted to give a Cliff Notes version of the new ACOG Committee Opinion 736 on optimizing postpartum care. They're now recommending an initial assessment within the first 3 weeks to identify acute concerns. This can be either via phone or in person, and is especially important for identifying mood disorders. High-risk patients should be seen 1 to 3 weeks after delivery. And all patients should then have a comprehensive visit no later than 12 weeks, where the components of postpartum care are discussed. As we touched on at the beginning, these components are mood and emotional well-being, chronic disease management, infant care, reproductive health planning, sleep and fatigue, physical healing, infant feeding, and sexuality. Whew, we covered so much today. I appreciate everyone's attention, and I hope you leave feeling like you have some answers in your back pocket for the next time you work with a postpartum patient. To summarize, we talked about the 4th trimester, highlighting its importance in our patient population. Next, we reviewed a typical postpartum hospital stay for patients who deliver at Meritor. And then we spent the majority of our time today moving head to toe on the postpartum body, discussing everything from hair loss to wrist pain, lactation challenges, and pelvic floor dysfunction. I'd like to thank all the individuals who helped me put this presentation together and for their work taking care of the birthing people of Madison. I do want to put on a quick plug for the Meritor Baby Hour, which is a free postpartum support group for birthing persons and their partners sponsored by Meritor. Unfortunately, it's still online in the COVID era, but I'm hoping they move to in person again soon. Anyone who has a baby at Meritor can attend for free, and it's actually open to their partners as well. And it can be a really great support system for people who are kind of feeling alone during this time. If you bring it up to patients, it's really easy to Google. You just search for Meritor Baby Hour and you can find it. I would love to open it up for questions and discussion. Ailes.
Crunched for time. Like you said, I feel like postpartum rounding, we are crunched for time in the morning and don't necessarily spend the time that we would like to like talking about these things. How do you think it's most helpful for like residents and then as we're attendings to like implement this information? It seems like it might be better kind of like prenatal counseling in the clinic. But I guess just wanted to hear your thoughts on that.
Yeah, great question. I would love to like turn this information into a patient-centered like pamphlet that people could get prenatally. My personal opinion is that postpartum resident rounding between 5 and 6 a.m. is a cruel source of torture for patients who may have just fallen asleep. So I think that there's nothing worse than being woken up when you finally just fell asleep and your baby's down. But I think when people are more awake, it's better to discuss this. So certainly if you're like going back later in the day, we're pressed for time as residents. There's not a lot we can discuss. And a lot of these questions actually do come up later. I think good times to discuss things like pericare is actually like when you're doing your repair. So as I'm explaining my repair to patients, I kind of talk through, you know, like this is the tear that went into the skin. You have these periurethral lacerations, which are near where your urine comes out, and you're probably going to have a lot of stinging. So then I talk through how to use the peri bottle. And I think that that may be a time when people are more likely to kind of hear that. And then at the postpartum appointment, you know, you can touch on these things and kind of see if people are having issues, but it's a good point. There's not enough time in the day to cover all of this. And I'm appreciative of ACOG for coming out with these components of postpartum care, but when our appointments are like 15 to 20 minutes for postpartum, it's very unrealistic that we're going to cover all of them. Ben. Thank you.
About an early postpartum visit, but we obviously don't do that in practice.
Mm-hmm.
Is there like do you think like we'll move toward that, or do you have obviously there are people who are at risk who we should do that for, but what's your thought on making the shift to that happen?
Another thing that I would love to see change, I think a lot of it stems from billing, which is unfortunate, and how swamped our clinics are, that making time for another appointment seems untenable. But I do think we're doing a disservice for patients who kind of go from being seen by a doctor weekly to all of a sudden just disappearing. Like you're just gone and you don't have a person to kind of touch base with. So I think kind of a good middle ground would be to potentially establish like a nursing pool that could contact patients via phone in the postpartum period and reach out and talk to people and just kind of see how they're doing. And as I mentioned, it's especially important to screen for mood disorders. And like a patient that I saw in the ED with perineal pain, which really was very expected and there wasn't a pathology. I think that if we are touching base with people sooner, they might be more likely to stay out of the hospital and just kind of be able to have anticipatory guidance when they're at home. Maggie?
I feel like for other kind of routine counseling, things like contraception counseling and stuff, there's a lot of resources and websites that can provide information for patients like, you know, bedsider and stuff. Are there any similar things for postpartum care that you can think of? Like, I know people have like apps during their pregnancy that tell them how big their baby is at times. Like, are there any things that can be useful to point patients to for postpartum care?
There's a resource that again, this is based on my own personal experience, but I actually did use it for a bit for this presentation called Kelly Mom. A lot of it is around lactation support, but she talks a lot about pregnancy. And as far as I could tell, I didn't find any like glaring issues with like medical evidence that I was seeing. So it can be a good resource to point patients to. I think like everything in gynecology, when I tell people, you know, there's information online, but just be careful. There's a lot of stuff that is not real. And so I encourage people, you know, if you have questions about something that you saw online, please bring them to me and we can talk about it. But the Kelly Mom is a good resource, and I'm seeing some nods. Dr. Ward, did you have a thought?
Thank you so much for this presentation. I think, you know, you mentioned as an intern feeling like you knew nothing, and I just want to echo that even after 4 years of residency and then having a baby, I knew nothing also. So it's not like that was going to change in your 4 years. I think something that you touched on really briefly on one of your slides that I think is worth pointing out, because I also recently learned this and thought it was really interesting, that retained placenta can be a source of not just like low milk supply, it's like no milk supply. So it's something I think to keep in the back of your brain on your differential. If you're like concerned about the possibility of retained placenta, asking patients about that, or if a patient calls and is like, I have been doing this and this, you know, there's very few causes of actual like absence of lactogenesis, and that's one of them. So I just thought that was interesting to point out. I also would agree with the using or suggesting Kelly Mom as a resource for patients.
Dr. Kelly? Not Kelly Mom, Dr. Kelly.
Ooh, that's loud. I agree. I love Kelly Mom, but the other resources that I do try to share with patients and I share during their prenatal care is the ACOG patient information portion of the website. And I usually like pull it up or send them a MyChart message with it because it has a lot of information during pregnancy for things that come up. And then they also do have information about postpartum care. And then ACOG also has a pregnancy book that if patients want more information that I recommend as well, that includes information about postpartum care. So I think those are good resources. There's lots of different books, but I think just having something that you can share with your patients. So like my two big go-tos are Kelly Mom and ACOG. Great job, Jesse. I had two other things for the sitz bath. That's so important. I feel like we say that all the time, like, oh, just take a sitz bath. But how do you do a sitz bath is a different layer. And you can have the sitz bath basin ordered and they can bring it up from central supply at the hospital so that your patient can go home with the sitz bath. And then what that does is it sits under the toilet seat. So it's like a little tub that's just for the butt that goes in the toilet that you fill with just water, and you lift the toilet seat up and it sits on top of the toilet, and then you put the toilet seat back down and you sit on it.
I didn't know that. I was just thinking
and we have them at the hospital. And so we can have the nurses order it and they bring it up from central supply. So when patients have like an oasis tear, we should be ordering those for patients and talking to them about a sitz bath. And then the last thing was you had mentioned vaginal estrogen. If someone doesn't want to use cream or is having pain with the cream, do you know of other options that you could use for those patients?
I guess my concern for a more systemic option would be that it could impact lactation more just because it's a systemic therapy, but you could do like as a vaginal tablet.
Yes. So the same things that we use for genitourinary syndrome of menopause, there are 3 different choices. We can use vaginal cream, vaginal tablets, and there's also a ring that works for 90 days. That's still only local estrogen. It's like 7.5 micrograms, or the like Vagifem tablets or Premarin or estrase cream. Those are all local estrogen, and people have different preferences about the mode of delivery.
I spent some time on that applicator because I had a patient in RCC that I prescribed that to, and then she came back and said she wasn't using it because the applicator was painful. So I do think that that's important to counsel people if you're going to send them with the cream to kind of talk about that the insertion of that may actually be painful. And so that's another reason to consider a different modality.
Yeah. And I think some of the creams actually have a little alcohol in them. So if the vaginal tissue is atrophic and then you're putting that in, it's going to burn. So I usually counsel them about that it might burn, but as you continue to use the estrogen, that burning will get better. But also they could use the pill, which is a much smaller applicator from a diameter standpoint.
Yeah, great presentation, Jesse. I was curious about, it's been a couple of years since I read the DAMES study on antenatal milk expression. Do you recall, did they actually talk about how the milk was expressed, if it was hand expressed or if it was with an actual pump?
I believe it was hand expression.
Okay, I thought so too.
Yes.
But that's important too in your counseling of patients, that you're not telling people to use a breast pump if people are going to be doing antenatal milk expression, because that is what's more associated with the preterm contractions. And it's not needed.
Yeah.
Right.
And colostrum is hard to get out with a pump as well.
Yeah.
So yeah, great point. Thank you.
Absolutely.
Thank you guys.